Coming to the IR part of it, one part is where Gunjan rightly mentioned that we can sort of get the patient for the surgery, the preoperative, where we can do chemo, radio embolizations or a portal vein embolization. But a lot of my treatment still is in the field of inoperable tumors, where we are using RFA, and RFA slowly is RFA or microwave is slowly picking up in our country. We're still not as good as the West in getting the numbers, but we're slowly picking up. But the bulk of my work is chemoembolization and now even radioembolization, or what I prefer to use it as selective internal radiation therapy. And I think Mohan will talk about the chemotherapy point of it. So these are the type of lesions we normally get, tumors in inaccessible locations, tumors, majority of them obviously with cirrhosis, multiple lesions which are not suitable for either transplantation or resection. And portal vein thrombosis is one of the bugbears which is there. And that is one of the treatments also we land up taking. So to go through is the local ablative therapies which we are doing is in the early stage HCCs. You can even use that as a curative procedure. But for the palliation ones, which we are using mainly, what I use mainly personally is the radiofrequency ablation and now the microwave ablation. Cryoablation has recently come into India, but still not freely available because the machine is pretty bulky and it requires to be bought by the hospital. I don't have much experience with ultrasound, laser, and electroporation because it's not using it too much. So main experience mine is mainly with radiofrequency ablation and microwave ablation. The criterias, if you go strictly by the criteria, single HCC less than 5, 3 HCCs less than 3, no significant coagulopathy, and preferably a child's A or child's B. Ethanol, percutaneous ethanol injection, I have done it in the earlier cases, but you need a very small lesion and it can be done at ultrasound guidance. You need a good sedation or sometimes even general anesthesia because the pain can be significant. And it's a basically uncontrolled diffusion, so good for very, very small lesions. But at the moment, we are not using too many of doing this. Mainly, it's a radiofrequency ablation where we are using the RF probe, which all of you know generates RF waves, which results in heat and causes coagulation, necrosis, and death. This is one of the machines which we use. Mainly, I do it under CT guidance, under general anesthesia, and that's how we do the procedure. Limitations, as I said, large numbers, large size, non-accessible lesion. Peripheral location is one of the limitations for RF because it causes a burn, nearly a 1 centimeter rim, and you can cause a liver capsular injury. Adjacent vessel, which cause the heat sink, and if the main bile ducts or any intestinal loops are close to it, there are ways to get out of it. We can create a plane with a saline plane for peripheral locations. But the other way to get out of it is also using a microwave ablation, where it's a thinner needle with a 14.5 gauge microwave antenna. This ablation is mainly based on electromagnetic waves, and that causes agitation of water molecules in the tissue and produces friction and heat, and that causes the cellular death. The advantages over RFA, which I feel microwave, is the higher intratumoral temperatures, faster ablation times. Hence, it can be used for peripheral lesions and even vessels which are close to, even lesions which are close to vessels. The pain is much lesser. You can use multiple applicators, so you can target slightly bigger lesions, and no grounding pads. The only disadvantage which I feel of microwave right now is the cost. It's a little more expensive than the radiofrequency ablation procedure. Something which is interesting is the cryoablation, where it mainly works on the Joule-Thomson effect, where there's a freezing and thawing mechanism. I've done this for a couple of renal lesions, but not for any HCCs. And but the advantage is what it's known to know that you can see the ice ball very well. There's no causation of severe pain, and there's lack of severe damage to great vessels and the gallbladder. So cryoablation is something which is coming in, but it's still not used frequently. I've done a couple of cases with a couple of colleagues outside, but not too many, not a single one in Bombay still. The bulk of our work is chemoembolization, and I still feel that's the gold standard. And I just read a paper just today, where old is gold, and repeatable chemoembolization does work very well. And especially in our country, I think it's still one of the treatment of choices. and I would still use it as a first line of treatment. Although we have much people talk a lot about DC beads, but I still feel the results with the lipiodol chemoembolization with a single drug like cisplatin, or sometimes even a combination of drugs like cisplatin, doxorubicin, and mitomycin for smaller tumors works better. And the earlier response rates were a little dismal. They're not very happy with 35 to 52% response rates. But now response rates have definitely increased up to 75, even up to 80%, because we're going super selectively into the lesion using a much lesser dose of the chemotherapy agent and just targeting the lesion with the specialized microcatheters which we have. For those who are keen to know why we can do a chemoembolization, because all tumors obviously are supplied mainly by the hepatic artery, and we can go in and actually block the blood supply because the portal vein is got good flow. These are the indications where we would normally use it: is an asymptomatic unresectable HCC, preserved liver functions, no extrahepatic spread, no portal vein invasion. This right now is a little debatable. We can even use it with portal vein invasion, with portal vein thrombosis if you're going super selective. And you can use it for mainly preoperative patients and to reduce the risk of tumor progressions in patients waiting for transplantation. A lot of the earlier contraindications of TACE are challenged with the superselective delivery. And in fact, even now, even if patients who got extrahepatic spread, with the excellent treatment done by Mohan and even lesions in the lung. And the only contraindication which I would feel is that there's an intractable systemic infection, or a patient child C with obviously advanced bilirubin and very, very hepatofugal portal flow. So for this is, I'm sure all of you have known what a chemoembolization picture looks like. I'm not going to stress too much on it. And you can see a lesion there, inoperable lesion with cirrhosis, and you can go inside the hepatic artery, super selective. This was the picture purposely shown to you, that where we used to do non-selective years back. But now what we are doing is taking a microcatheter, you can see. So through a catheter, we go with a small catheter all the way into the branch supplying the lesion, so that one, you reduce the dose of the chemotherapy agent. Mainly, you avoid non-target embolization, so you can preserve the liver function, especially in patients who've got a borderline liver functions. You don't want to get them into liver failure, and we can get very good results with chemoembolization, especially when we're going super selective. Even these patients who are fit for surgery, but you need to wait, you need to bring it down in size, or even wait for liver transplantation so it doesn't progress, we can do a chemoembolization and get it. The complications right now, especially with super selective chemoembolizations, are very, very few, mainly nausea, vomiting, fever. Non-target embolization has become actually very, very less because of the super selective way we are going. And very low risk of renal failure and liver failure, which are occurring right now. There are newer techniques for TACE, which we're using, drug-eluting beads. We have used some of them, but the only reason with drug-eluting beads is, again, in India, it adds up to the cost, especially when we are doing multiple sittings, which are occurring with drug-eluting beads. Sometimes adds to the cost, and that can create an issue. A lot of the TACE is now combined with the newer multi-kinase inhibitors like sorafenib and the new drugs, which I think Mohan will elucidate. And we are using these in combination, and we are getting pretty good responses with TACE as with the combination of systemic chemotherapy. One practical point is, for those who are doing it, is that if you're referring a patient for a chemoembolization or a radioembolization, please see that you don't start the systemic therapy before. So that makes my procedure a little more difficult, because it causes spasm of the vessels, and we don't get a very, very good response. So we prefer doing a couple of sittings of chemoembolizations and then starting the oral chemotherapy drugs, which Mohan will elucidate soon. Gunjan stressed on radioembolization, and it's one of the, I would not say newer therapies. We've been using it for the last 10 to 15, nearly now 15 years. We have been doing radioembolization. And the issue is, I don't like to use the word radioembolization. It's more of selective internal radiation therapy, because you're not embolizing anything. You're basically getting beads deposited into the bed of the tumor, and that radiates mainly with yttrium-90. The ones which we use mainly are the yttrium-90 spheres, which are there. Mainly two companies in the world manufacture it, TheraSpheres and Surspheres. And there are two types, resin and glass. Won't go too much in detail about them right now. There are various types of people who use internal radiation for this treatment. You can use holmium, you can use rhenium. Still not available freely in India, although the rhenium and holmium are much cheaper. And actually, we can start using them in India, reduce the cost. It's basically a beta emitter, which is the radioactive isotope. The tissue penetration is exactly for the tumor, so does not cause any surrounding radiation. You don't need to isolate the patient, or you don't. People can still meet the patient even after doing the procedure. There are surspheres, which are the resin microspheres, which are slightly larger, and this is made by the company in Australia. Then you have the TheraSpheres, which is a company in Canada. Both actually are good enough, whichever you use. Each company will obviously try to say one is better, but I see frankly no difference between the two. Radioembolization, the internal therapy basically is used for increasing the chances of liver transplantation. It's also can cause, also helps to, if you radiate the entire lobe, it also helps to cause some amount of contralateral liver hypertrophy, and also it can help to promote resection. Main use, frankly, which we used to use it earlier, was when it was had portal vein thrombosis. And because it's the beads are so small that they even can go into a malignant portal vein thrombosis and even sometimes open up those portal veins. So frankly, out of all the radioembolizations or so in therapies which I have done, I've seen this happening only in a couple of cases. It is sort of an expensive procedure. There is a workup associated with it. There's the two stages. One is a planning stage and one is the injection phase. The planning stage is actually the most important one. You need to get obviously a good blood workup, obviously, which has to be done. And in the planning stages, what we do is we do proper celiac and superior mesenteric angiography. We identify all the blood vessels supplying the lesion. If there are any GI branches which are very, very close to the supply, because you don't want those beads to sort of reflux back into the GI tract, because they can cause a very bad radiation gastritis. So the person doing the procedure has to be experienced enough to do plan this procedure very well, identify mainly the D1 branch, sometimes which comes from the right hepatic artery, a very small branch. It takes a lot of technical skill to get into that branch and block it. And you need to map the perfuse segment of the lesion, and then we inject something called technetium-99 MAA, which mimics yttrium-90, and we see how much of that remains in the liver and how much of that goes into the lung. We calculate the lung volume calculation. If it is less than 20%, then we can go ahead with this procedure. There are various techniques to even go ahead if it's up to 30%. Won't go too much in detail right now, but maximum, I would say, if there's a less than 30% lung shunting, then you can go ahead with the internal therapy treatment. Anything more than that, then we should not be doing this procedure, because if any of the yttrium goes into the lung, it causes irreversible lung fibrosis, and that's just terrible. You don't want that to happen. Once you get the dose calculation after doing a CT volumetry, then you inject the dose like we have done in this patient, a 63-year-old lady, HCV positive. She actually could have gone for a chemoembolization. We gave her both options. She opted for radioembolization, and that's what we did. We mapped the entire treatment here. We blocked the gastroduodenal artery. This is one of the first few cases which we did. So we used to block the gastroduodenal artery prior so that no reflux occurs. But now, if you ask me, I would go all the way with the microcatheter into the blood supply here and inject it without blocking the GDA, because we're going super selective. We get a CT volumetry, which is done like shown in this picture here, calculate the dose, and then we inject the dose. And that's what we get a picture when you see after nearly 6 weeks is a complete absence of vascularity and necrosis sort of forming into the tumor. And the AFP level comes down to normal and no uptake on the PET scan. You can even use this in patients with portal vein thrombosis, like the 62-year-old lady, large HCC with portal vein thrombosis. And this is what it looks like. This is a Surspheres container, where this is where the beads are kept. As you can see in this container here, this is a radioprotective cover, which is there, the shield. And we are standing a little away, and we're injecting the dose from the microcatheter, which goes into the patient. And that's how we are giving the dose into the patient. And this is what we do. We go super selectively. We calculate the dose, and this patient required 2 GBq of dose. And we are given this. You can even use it for multicentric mets, like in this patient, and radiate the entire lobe relatively safely. Why we can do that is because beads do not cause embolization. They're so small, they do not block the blood supply to the to the liver and actually radiates the tumor from inside. And hence, you can do this even with a portal vein thrombosis. You can see mainly all the procedures are now, by a rule, we use a microcatheter, which is a small catheter which goes all the way super selectively, and we inject the Y90. You've got a good control of this lesion in this multicentric HCC. Complications are actually pretty less. There's a post-radioembolization syndrome, which causes fatigue, nausea, but settles down within a couple of days. At times, if patients have got, if you're not calculated the dose well, you're not done a proper procedure, you can get severe hepatic dysfunction. And with good planning, we have never seen radiation pneumonitis or GI ulcerations, but it has happened in few patients of some operators. And these are just two terrible complications, which actually are now, you cannot defend them happening, because if this happens, means you're not done a good planning. So they should never, definitely not happen. Majority of our HCCs are in selective internal radiation therapies are HCCs, but they're even using them for some cholangiocarcinomas, colorectal mets, and even neuroendocrine mets, which are there. The literature, as you can say, is in favor of internal radiation therapy. They've still not made the BCLC criteria, but like Gunjan rightly mentioned, slowly it will make its way through. But practically, if you ask me, right now, especially for our country, it's a pretty expensive procedure. The entire procedure would cost upwards of nearly 10 to 12 lakh of rupees. So we need to consider which patient we're giving to and what benefit we are adding to the patient. Chemoembolization is much cheaper and also has pretty good results, which we're dealing with. And we can combine various modalities in HCC. So this is an 84-year-old gentleman with a large HCC with a high AFP. And you can see Doppler showed a large lesion with classical HCC features. CT scan showed a large lesion. We subjected him to two procedures with standard chemoembolization, which is there. After 6 weeks, we reduced the size. And then the MRI showed mild liver renal dysfunction occurred. So we did a plain MRI, which also showed a lesion which is there. And then we RF the lesion, and we got it down to pretty much control. And control the lesion for a long time till the patient sort of passed away with due to just old age and lived with this lesion pretty well. Obviously, that was a very nice case. That we also had some complications where patients have gone into liver dysfunction with chemoembolization. We have to realize that. And the only drawback I see is that a lot of patients and a lot of physicians still feel that after doing one sitting, it's enough. Chemoembolization is a repeated procedure. You need to keep on following it up by CT scan, seeing the MRIs, seeing the alpha fetoproteins if they're still going up, or if you see a residual hypervascularity, then early venous washout, you need to do repeated sittings. And that's what needs to be explained to the procedure. It's not a curative procedure. It's more of a control or a palliative procedure, which you're doing. What they say about radioembolization or internal therapy is that you can do it in one stage. But in all practicality, when you see a large lesion, it does help to control, but sometimes you do need to follow up with selective, super selective chemoembolizations after even doing internal therapy. Just to sort of conclude the last thing with an HCC, although this is not a classical HCC, it's a cystic sarcoma of the liver, but what we are doing is portal vein embolizations, mainly to hypertrophy the contralateral lobe. And what we use at times here is either glue, or we use PVA particles and gel foam. And we literally go in and block the entire portal vein on the whichever lobe needs to be resected out. So the other there's a compensatory hypertrophy. And we have got very, very good results with our technique because we go to each branch and we embolize each branch. I think Gunjan, Raj, and Prasad will corroborate with it that whatever cases we have done for them, we have got pretty good results. And there's been a decent hypertrophy which has occurred, and they could go ahead with their surgery. And this is how it looks in this case, where we achieve compensatory hypertrophy, which is there. So my take-home message in this, that this is a team effort. It's not that my procedure is the best, or Prasad's and Gunjan's procedure is the best, or chemotherapy is the best. It mainly requires a combination treatment discussion between all the three stakeholders in this, and whatever is best for the patient, we should offer it. You can combine a lot of treatments with these procedures and try to give the best results for what is one of the most devastating cancers I have seen. Thank you.